This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. I'm Jacob Schwartzman. I'm here today with Dr. Paul DiMuzio, the Director of the Division of Vascular Surgery at Jefferson, as well as Sarah Deery, who is currently a Vascular Surgery Fellow at Johns Hopkins. Today we are presenting our second Meet the Author segment as part of our collaboration with the Journal of Vascular Surgery, and we are also piloting our first ever journal club as part of this collaboration. We will discuss one of the articles from the October JVS Editor's Choice, as well as some relevant papers in this area selected by the first author. Links to these articles will be provided in the show notes. On this coming Sunday, December 8th, we will be opening a public Twitter forum/extended online discussion where you can log on to discuss these papers, as well as any other literature relevant to the topic. In the meantime, any questions regarding these papers can be sent to @JVaskSurge or searched via #VascularJC. We will also be opening several polls on Twitter, as well as posting some free response questions. We hope to get a lively conversation going. Our guest today is Dr. Caitlin Hicks. She is an assistant professor of surgery in the Division of Vascular and Endovascular Therapy at Johns Hopkins in Baltimore. She received her MD from Case Western in Cleveland and completed her general surgery residency and vascular surgery fellowship at Johns Hopkins. She has special interests in health services research and is an appointed member of a CMS clinical expert subcommittee tasked with refining peripheral vascular disease cost measures. We actually had Dr. Hicks on the podcast recently to discuss the overuse of lower extremity interventions in patients with claudication, and I encourage our listeners to go back and listen to that episode. Welcome back to the podcast, Dr. Hicks.
Thanks for having me. Glad to be here.
So I'd like to just start off with some general questions and to get to know you a little bit better. Last time you were on, we heard a little bit about how you became interested in vascular surgery and what drew you to the field. Can you talk a little bit more about your research background and what your general research interests are?
Sure. So I really got interested in research in college, sort of looking around what to do during the summers. I ended up working in a couple different labs at Harvard Medical School and really developed a passion for clinical investigation and really basic science investigation at that time, not really knowing or understanding the difference. When I went to medical school, I actually was in a track within Case Western that was through Cleveland Clinic, and that included a year of dedicated research, which I spent at the NIH. I was doing some translational sepsis research and got to live on campus and work with a bunch of NIH researchers, and it was really exciting and sort of ignited my passion for research further. I ultimately ended up getting a master's in clinical research during my time at Case Western. And then when I came to Johns Hopkins for residency, I reached out to a bunch of mentors and things that I was interested in and was able to get involved in a bunch of different outcomes-related projects and have sort of just taken it from there.
Sounds like you've had fairly intensive training in research. Do you have any advice for any trainees in vascular surgery or in any other surgical fields who are looking to get involved in research who maybe don't have as much training as you've had, or if there are any opportunities that you know about to get that kind of training?
Yeah, I think the best advice I can give anyone who's training is just to ask what you can get involved in. There's a lot of different research going on in institutions that you might not even know about. People especially clinicians, tend to not talk about their research in the clinical setting so much. So when you're a trainee, you may just not even know that there's an opportunity to get involved. Everyone in our division is doing their own various types of research, and many of us don't really actively recruit people to help us, but we're always happy to have the help and happy to teach them what we know. Whether your training level is 0 in research or whether you can write your own code and run your own stats, there's definitely something for you to do. Be it writing chapters or getting involved with writing an introduction or a discussion on a paper, or perhaps formulating your own clinical question of interest. So I think having no formal training in research shouldn't deter people from getting involved in research. The first step is sort of making that leap and reaching out. I think if you do have some more formal training, it's obviously a little bit easier to sell yourself, but certainly all the attendings that are doing work are looking for good help and people who are passionate just to get involved. So certainly we're not going to judge someone based on not having done it before.
Well, I hope some of our trainees are listening and will look for these opportunities, and we could definitely use some help on the other end of that in terms of getting things published. We're always happy to have more people on some papers.
Absolutely.
Can you tell us a little bit more about how you became interested in health services research?
Yeah, when you go into surgical residency, I had done, as I mentioned, some translational and basic science research before, but as you get sort of clinically busy within surgery, you start to realize that those pathways take a lot of effort. And not to say it can't be done, there's some people that do it extremely well, but it definitely takes a certain type of personality and a certain dedication to be able to build a basic science lab or a translational lab from the ground up. For me, what really interests me in health services research is that it's directly relevant to the clinical population that I'm treating. So as I'm doing surgery or working in the clinic or whatever, there's questions that come up, and using a health services approach, you can sort of come up with ways to immediately address those questions. And certainly a lot more work needs to be done in the background to look at physiology and etiology, et cetera. But I think for me, health services research is sort of the rapid reward approach to answering clinical questions that are important.
And what are some of the tools you've used historically to perform some health services research? Are you looking at mostly institutional data or nationwide databases available through your institution? What are some things that people should look for when trying to get involved?
Well, this will date me a little bit, but I've been doing it long enough that when I started, the use of nationwide databases was non-existent, or maybe just in early development. So sort of the thing then was to use institutional databases. Those are great. Obviously if your institution has a very unique skill set or treats a unique population, those can be very fruitful. I think the downside with using institutional databases is that usually they're limited in numbers. They're very specific to the treating institution, and oftentimes they're not pre-built. So if you're interested in asking a question, to answer that question, you need to go build a database, collect all the information, and then go ahead and define your variables and your outcomes and start analyzing it. The beauty of having nationwide databases available to us is that you get a lot more patients from a lot broader perspective, and you can ask questions and immediately go to those databases to answer them instead of having to build them up from scratch. So I think there's sort of a role with everything, but I've definitely transitioned from using institutional databases to nationally available databases recently. That being said, we do have a couple of ongoing institutional databases, and the database that the paper that we're going to discuss today actually uses that database. So certainly there's a lot of benefits there, but we've put a ton of work into building this, and it's been about an 8-year endeavor, so it doesn't come easily.
Well, that's a very nice segue. On that note, let's jump into discussing the paper. This paper was featured in the October 2019 issue of the JVS. It is titled Contribution of 30-Day Readmissions to the Increasing Costs of Care for the Diabetic Foot. Just to briefly summarize, this is a single-center retrospective analysis of inpatient costs over 4 years from 2012 to 2016, of index admissions and subsequent unplanned 30-day readmissions for patients with diabetic foot ulcers. The study looked at 249 total admissions for 150 patients, where the readmission rate was about 22%. The most common reason for readmission was the foot wound at about 49%, followed by bypass wounds, so surgical wounds created from the attempts at revascularization, and then renal complications. Almost half of the readmissions required some sort of surgical intervention, whether pediatric or vascular. The mean hospital cost didn't significantly differ between the index admission and the subsequent readmission. However, readmissions did significantly have higher overall costs, approximately $79,000 versus $29,000. And not only that, but hospitals were making less money, so the net margins were $3,900 versus about $1,900. Just to put everything in perspective, over the 4-year study period, $7.9 million were spent on the care of the patients overall, and of that, $1.2 million was attributable to readmissions directly. So, Dr. Hicks, what sparked your interest in this particular area and made you decide to look at this problem in general?
Well, so Dr. Boularaj, Christopher Boularaj, who's one of my partners and was my program director back when I was training, and I have sort of built this database of diabetic foot ulcers over the past number of years. We saw a population coming in through the hospital, through the emergency room, patients with terrible foot wounds due to the underserved community that Johns Hopkins is situated in, and these patients really just have no care at all. So over the course of a number of years, we established a multidisciplinary team that takes care of them, and that consists of a vascular surgeon, a podiatric surgeon, infectious disease doctors, endocrine doctors, and then an orthotist, prosthetist, and a plastic surgeon when necessary. As we sort of developed this care model, we've seen our outcomes improve significantly, and we've reported this in a variety of publications previously. This sort of drove us to build this data set so we could prospectively follow these patients over time and see exactly how they're doing when we do certain interventions on them versus others. Do they do better? And can we really improve their overall outcomes, improve their wound healing, and decrease their risk of major amputation? This study that we did sort of builds on the previous work that we've done within this cohort and really was aimed at looking at readmission rates. We've noticed, and our administration had nicely pointed out to us, that our readmissions for diabetic foot ulcer patients was on the high end. And so we were looking for a way to improve that. And one way to do that is to ask the question, why are patients being readmitted? Because if you know why, then you can sort of try to implement a system to try to decrease that. And that's what drove this paper ultimately. We had already done a paper looking at overall costs of care related to diabetic foot ulcers, but we hadn't really looked at readmissions specifically and how those contributed to those costs. And that's what we were doing here.
Dr. Hicks, Paul DiMuzio, on behalf of Journal of Vascular Surgery, thank you again for being with us, and congratulations on a fantastic paper. It really rung true to me when you said our hospital approached us and talked about readmissions. We recently looked at a study trying to decrease our readmissions and costs on vascular incision complications in the groin. And it's funny, it was really driven by, hey, what's going on with you guys? And then we sought to dive deeper into the problem. And I just want to commend you not only on giving terrific service, but also service that is so important and common in this country with the diabetic.
Yeah, thanks so much, Dr. DiMuzio. I mean, I think that rings true, and that's sort of the beauty of clinical research and health services research. You have this clinical problem and clinical question, and you need an answer quickly because the administrative people are banging down your door. And the way to do that is to look at some sort of data, be it your own data or national data or what have you. And this was our approach to doing that, and it's definitely assisted in our treatment of these patients, both overall and in terms of readmissions. I think, not to jump ahead too much, but within this paper, we report our readmission trends over time, and you can see in the figure that the rates go from over 25% in 2013 to down to just above 10% in 2016. So we've definitely seen an improvement just by looking at this, and our goal is to get this even lower.
Yeah, I thought that was an incredible part of the paper. Do you attribute that trend to maybe some care on the outside that you started to stress, or what other things do you think contributed?
Absolutely. As I mentioned, Johns Hopkins is located in a place where we get a lot of patients coming in that don't have established care. So they're not seeing their primary care doctor. They're not getting their regular foot exams that diabetic patients are supposed to be getting. And so once we've finally seen them through the system, we can get them plugged in with the care that they need. And that's with us in our multidisciplinary team, as well as other care, including their primary care physician, and getting them sort of just plugged into the healthcare system in general. And I think by doing that, we improve these patients' health status, both with relation to the foot and overall. And ultimately, that allows them to do better with how we're treating them.
Hi, I'm Sarah Deery. I'm one of the vascular fellows at Hopkins working with Dr. Hicks. And so I've been able to see this practice in real life. And I'm also very impressed by the readmission rates here. And, was wondering how much I saw that in the paper, all patients that were not admitted were excluded from the analyses. But, how many patients do you think overall percentage-wise are not ever getting admitted and are able to get all of their foot care and are able to completely heal without ever needing an inpatient admission? And do you think that is overall reducing cost, or are there still outpatient costs that were not being accounted for?
Yeah, that's a great point, Sarah. So I think, when we started this endeavor, we were seeing pretty much every patient getting admitted because essentially they were being admitted through the emergency room. As we've moved forward and we've developed contacts within the community, and the clinic has actually developed a little bit of a reputation, at least locally, we're seeing a lot more patients being sent to us in clinic and a little bit earlier in their wound stages. We're also seeing the patients that we initially treated on a regular basis in follow-up. And so as those patients develop recurrent ulcers, and they do, the going rate, I think, is around 60% at 2 years for ulcer recurrence in diabetic foot patients, we're able to intervene earlier. We've published on this actually recently, conveniently, and our downstaging rate in recurrent ulcers is extremely high. It's about 60% of the patients are downstage, and that means that they come in with less severe wounds on their repeat presentation than they did initially. And by downstaging them, their burden of care, including their need for admissions and then subsequent readmissions, goes down. We actually have looked at the overall costs in terms of both inpatient and outpatient procedures. the inpatient costs are still substantial, but I think, and the outpatient costs do contribute, but the outpatient costs are significantly less than the inpatient costs. As we all know, hospital admissions cost a fortune just for the bed and the various care, never mind the operating room and the supplies that you're using in there. So as we can shift these patients from an inpatient approach to an outpatient approach, we're going to see a decreased overall cost. You're never going to get rid of costs completely because these patients need care in some form. But I think if we can see that shift move towards the outpatient trends over time, we're definitely going to see an improvement, and we're not there yet.
I just had a question about, has the definition of your readmission changed over the years? A lot of what we've done at our institution, instead of admitting the patient, is put them in an observation unit. So it's not really technically a readmission anymore, but the billing is through an observation code and whatnot. I'm wondering if any of that's going on at Hopkins.
That's a great point. And I mean, it's definitely something that, I think everybody's trying to do, especially as, Medicare is looking closer at readmission rates and administrators looking closer at readmission rates. Unfortunately, in this population, that doesn't tend to work very well for a couple of reasons. One, most of these patients, if they are being readmitted for some sort of reason that needs a reintervention. I think in this paper, the reintervention rate on readmissions was like 50%. So those people are being admitted directly to the hospital as an actual admission. The other issue with it is if you're trying to do a 23-hour OBS and get that patient set up with whatever they need as an outpatient, I think oftentimes the patients that are struggling with readmissions are the ones that are a little bit less compliant or have fallen off in their wound care or have just not appropriately been plugged into the system so that we were able to get ahead of the whatever issues going on. And so for that reason, we tend to admit the patient so that we can sort of understand both the health and social challenges that may be affecting them and whether that patient would be better off served in a rehab facility where they can get regular nursing care or trying to set them up for success in the future. So while I can't say that we don't do that, it's certainly on our minds. I think most of the patients, even if we try to admit them for observation, end up converting to an actual readmission.
So I have to say I'm pretty impressed by the excellent care you've been able to provide before patients even reach the hospital. But once they're there, can you tell us a little bit more about the multidisciplinary aspect of it in terms of who's responsible for what and how can other institutions try to model what you do at Hopkins in order to provide the patients with the best care?
Sure. So whenever these diabetic foot patients come through the emergency room, they're admitted to the vascular surgery service no matter what. Unless they have some other terrible medical comorbidities going on that, is not appropriate on our service, such as having an active MI or what have you. If they have a diabetic foot wound and that's their primary reason for admission, they are admitted to us because that allows us to manage their care. There's 2 vascular surgeons involved in the service. Dr. Christopher Bulleraj is the director of the service, and he's the one that initiated this process. And then I'm the research director for the service, and I take care of patients as well. We have one dedicated surgical podiatrist who works exclusively with us, and that's basically all he does. So we have a dedicated team for that. And then we have an endocrinologist that, while he has his time split to other places, knows that these patients are a priority and makes sure that they're seen by the endocrine service expediently. So essentially, when patients are admitted, they immediately see a vascular surgeon, a surgical podiatrist, and an endocrinologist, all within their first admission day. And then we're able to sort of go from there. Infectious disease is usually plugged in quite rapidly, and we have a dedicated wound care nurse that helps with dressings and wound care evaluations, etc. It's certainly a lot of work, and it's a lot of work up front to get the program established. Looking at our cost data sort of overall, our net margins were negative on this for about 3 or 4 years before we finally converted to positive and are showing a mild profit. Not that you do this for profit, but obviously the bottom line does matter. So I think, institutions or services that are looking to set something up like this have to think about it as a long-term investment as opposed to a short-term investment. It is going to be a little bit of money and time up front, but ultimately your patients are going to get improved care. And there are a number of papers in the literature showing that a multidisciplinary approach to diabetic foot ulcers and other conditions will save money in the long run, but it's just not going to happen right away.
Thank you very much for that summary. How do the findings of this current paper compare to some of the other literature on the topic?
Yeah, so I think this paper is a little bit unique because it specifically looked at costs and charges related to readmissions. And honestly, for diabetic foot patients, this has not really been reported. But there are other papers in the literature that deal with costs of diabetic foot ulcers. There was a great paper published in Diabetes Care back in 2004 by Karen Stokel and her colleagues. And I know we're going to put the link to this in the show notes. But essentially, their goal was to report costs of lower extremity ulcers among patients with diabetes. They used a prescription solutions database, which is a longitudinal claims database, including patients from California, Oregon, Oklahoma, Texas, and Washington, to evaluate just over 2,000 patients with diabetic foot ulcers in the early 2000s. They reported overall costs of care related to treatment of wound episodes that averaged around $13,000. That's a little bit lower than what we've reported in the past and what we report in this paper. But again, this paper is almost 15 years old now. So I think that you're seeing some cost elevation, both from inflation and also a change in technology with revascularization as well. But certainly this was sort of one of the first papers that really took a deep dive into costs directly related to lower extremity ulcers and was a great resource as we put together this paper that we currently reported. There was a second paper a little bit more recently that was published in Diabetes Care again in 2014 that looked at the burden of diabetic foot ulcers for Medicare and private insurance patients between 2007 and 2010. That was a little bit of a different approach. They were comparing basically costs for Medicare patients versus privately insured patients. But in doing so, they also report overall healthcare burdens and costs and charges for each different groups. And again, the numbers that they're reporting are very similar to the numbers that we're reporting, which is encouraging because it suggests that, using these three different sets of databases, we're all coming up with approximately the same range of numbers, and also sort of shows that you can do this type of research using a variety of different approaches, and all of them can sort of contribute together to offer more details and sort of tease out the issues that we're truly dealing with.
Thank you for summarizing those two papers for us. One of the things I noted from the second paper you mentioned, there was a significantly higher cost associated with people who had progression of their ulcer disease from less severe to more severe, and that the cost associated with that was more than 6 times that compared to people who didn't progress. So it behooves us as clinicians to do our best to prevent that from happening.
Absolutely, absolutely. And that data, which was published in 2014, has since been replicated both by our group and a couple of other groups, actually using the Wi-Fi stage, which is an SVS classification system for communicating the severity of these ulcers. And there's a huge range in costs related to Wi-Fi stage. At our institution, treating a Wi-Fi stage 1, which is your most basic stage, costs about $4,000 from when you initially evaluate that wound until complete healing. Treating a stage 4 wound, which is extremely high risk, has about a 50% amputation rate according to the literature. It costs on the order of around $50,000 to get it from initial evaluation to healing. So that's a huge spread. And obviously, if we can move these wounds from stage 4s down to stage 2s and 1s, we're going to have a lot lower costs and better outcomes for the patient.
I agree, and the outcomes obviously will follow. I'm just curious to hear, 35 patients requiring readmission accounted for $1.2 million in inpatient healthcare costs. Were you surprised by this number at all?
It's a sort of a stunning number when you think about it as, $1.2 million. But if you tease it out, those 35 patients had 43 readmissions, and that essentially equates to about $29,000 per admission. And that's right in line with the overall cost that we report. But it is a shockingly high number. And if you can think that at our institution, we spent $1.2 million in readmissions, imagine every institution across the U.S. combined. And this is where we're getting numbers in the billions of dollars for diabetic foot ulcer treatment in the U.S. Previous reports have suggested that the inpatient costs of diabetic foot ulcer care in the U.S. are around $1.4 billion annually. We have reported a 15% readmission cost burden, which would be equivalent to approximately $210 million in hospital costs. So if you could imagine that the readmissions we're having in these diabetic foot ulcer patients are literally contributing to over $200 million in healthcare costs. So even decreasing those readmissions by 10% would make a massive impact on the healthcare system.
Dr. Hicks, thank you very much for all the work you've done in this field. I'm sure your patients appreciate it, even if they don't know of all your hard work behind the scenes. We in the vascular community certainly do, and we look forward to hearing more from you, both in the Journal of Vascular Surgery and otherwise. One of the things we like to ask our guests, is there anything that you know in vascular surgery to be true, but that others may not agree with you about?
That's a great question and a really difficult one. I tend to believe that I just don't know everything. So if I think something's true and someone else thinks it's not, then I'm probably wrong. But I do know what's true is that usually you have to anticipate for the worst case scenario. and whatever can go wrong will go wrong. And some people may not agree with me, but I tend to find that is the case. But I do have a very black cloud, so that's the caveat.
I was just going to say that's definitely true for you. That might not be true for other people, but you've proven that everything that can possibly go wrong.
Well, you wouldn't be the first superstitious surgeon out there. What excites you the most about the future of vascular surgery?
I'm really excited about the ongoing opportunities for increased health services research, because I think a lot of the things that we're struggling with on a population level can be answered with the availability of these databases. And the Vascular Quality Initiative in particular is a great opportunity for collaboration across the U.S. by vascular surgeons for vascular surgeons. And I think utilizing that and sort of expanding it is going to allow us to answer questions that previously we were very reliant on administrative data and sort of making a lot of assumptions. I'm hoping that we can use that data to make a lot of forward progress on very specific topics that we have. That's from a research standpoint. As an overall concept about what excites me for vascular surgery is just the ongoing technology changes. I mean, even since we've started this multidisciplinary team here, we've seen a drastic shift from our open surgery interventions to an endovascular approach due to ongoing technology. And I think this is just going to continue to increase. And ultimately, these patients are sick. So I think, whatever technology advances we can have that will improve their outcomes and reduce their exposure to operative risk is positive.
Thank you very much. We definitely are looking forward to seeing more of these technological advances. And again, any of the new databases or systems in place for gathering data and putting out good papers that can improve our patients' well-being. We're looking forward to reading more about that. Last but not least, of course, we've recently heard that you became a mother, and we at Audible Bleeding would like to congratulate you on that. Another thing we like to ask all our guests, what are some of the things you like to do in your clearly copious free time when you're not on call, not doing research, and not busy with your baby?
Well, thank you for that. I think my favorite thing to do in free time is to travel, and we try to travel as much as we can. And that's not planning to change with the baby. He's just going to come along. He's already heading with me to Korea in the beginning of December here. So we're going to start with a stamp in the passport and move forward from there.
Thank you very much, Dr. Hicks, Dr. DiMuzio, and Sarah for joining us on the podcast today. For reference for our listeners, the two papers discussed by Dr. Hicks today were Costs of Lower Extremity Ulcers Among Patients with Diabetes by Stokel and colleagues from 2004, and Burden of Diabetic Foot Ulcers for Medicare and Private Insurers by Rice and colleagues from 2014. Both were published in Diabetes Care, and links will be provided in the show notes. As previously mentioned, we are launching a new initiative to discuss some of these papers as an online journal club. On the JVS Twitter account at JVSCurge, we will be posting several questions to you, our listeners, both as polls and as free response. These will be released on this Sunday, December 8th, so make sure to follow at JVSCurge and search for #VascularJC to get involved. Our goal is to generate a discussion of these papers, as well as any others that our listeners suggest which have looked at these or any related issues. Thank you very much for listening to this episode of Audible Bleeding. We would like to thank Lori Samuelson for her generous donation. Thank you for your support. We look forward to bringing you more content and would like to remind our listeners to please fill out our listeners survey so that we can continue to serve you better.